So therapy is a randomised phase 2 multi-centre trial conducted in 11 sites around Australia, comparing the activity and safety of lutetium PSMA compared to cabazitaxel chemotherapy in a group of men who have progressed after docetaxel chemotherapy and had mostly progressed also after abiraterone or enzalutamide. And the men received either cabazitaxel or up to 6 cycles of the experimental treatment, which is lutetium PSMA 617. And this is a novel radioactive treatment. It's a molecule bound to lutetium 177, which is a beta emitter. It travels around the bloodstream and binds to prostate-specific membrane antigen, or PSMA, and it's a novel way to deliver very high doses of radiation to sites of tumours. The lutetium 177 has only a 1 millimeter path length, so any damage from the radiation is really limited to tumours, and very little normal tissues are exposed to the radiation. So the primary endpoint of this trial was PSA response. So we compared the PSA before treatment to after treatment, and men who had a reduction in PSA of over 50% were considered to have a good response according to sort of international guidelines. And we saw a PSA 50 response rate in 66% of the men randomized to lutetium PSMA compared to 37% of men having the cabazitaxel chemotherapy. So that's a 29% absolute improvement in the primary endpoint favoring lutetium PSMA. So that's indicating higher activity of this therapy. So lutetium therapy was really very well tolerated. Most men had no significant adverse events after the lutetium PSMA. The main side effect that we saw in 59% of men was a grade 1 or 2 dry mouth. This was usually something that almost the doctors asked the patients about, and they said, yes, I have a dry mouth, but it wasn't causing the patient's particular problem. We also see dry eyes in 30% of men, and we see some hematotoxicity, which mainly is reduction in platelet counts or thrombocytopenia, and we saw a grade 3/4 thrombocytopenia in 11% of men. But really, this is an extremely well-tolerated treatment. No men on the trial stopped the experimental treatment because of adverse events, and importantly, there were no deaths due to the experimental treatment. Yeah, so the therapy trial was designed back in 2016, and at that time point, there was not a lot of data around efficacy of lutetium PSMA, but we did have some early data around PSA response. So this was an investigator-initiated trial. It was run by the ANZUP, Australian Cancer Clinical Trials Group, and as we designed this trial with ANZUP, we needed to decide how many patients would this trial include, and data was really only available around this PSA endpoint. So we powered and designed the study around this endpoint, but we do have secondary endpoints looking at progression-free survival and also overall survival, and we await some further follow-up to define those definitively, but they're definitely of interest. We did have an early readout of PSA progression-free survival, and that showed a prolongation of that endpoint with a hazard ratio of 0.69 favouring lutetium PSMA, so it was delaying progression compared to cabazitaxel. So in the therapy study, men had all progressed after docetaxel chemotherapy, and also 91% of men in each arm had progressed after abiraterone and or enzalutamide. So this was really as a third-line therapy, either cabazitaxel or lutetium PSMA. We know that the efficacy of using an alternative novel anti-androgen therapy, such as enzalutamide after abiraterone or vice versa, really has very low response rates. So we didn't consider that an optimal control arm in this group. So we really chose cabazitaxel as a very active arm. And this was supported by a publication last year in the New England Journal of Medicine, which actually compared cabazitaxel to crossover novel anti-androgen therapy, showing that cabazitaxel improved overall survival. So we think in this population of men, cabazitaxel is really an optimal comparator. Yeah, so the trial definitely shows that lutetium PSMA is a highly active treatment with a low rate of side effects. So it would be really interesting to use this therapy as a earlier line of treatment. Really, in this study, it was used as a last line of therapy in these men who had very few treatment options. So we would like to bring this out back as an earlier treatment. And in fact, we have already progressed to that. So the ANZUP group that have run this trial have two trials that are either open or about to open. One is called the ANZUP trial, which is comparing enzalutamide compared to the combination of lutetium PSMA or enzalutamide. That's bringing the treatment one step back. And I'm now leading, together with our oncologists, a trial called Upfront PSMA, where we're actually taking men with newly diagnosed metastatic hormone-sensitive disease with high volume disease, and we're randomizing them to the standard of care of docetaxel or upfront lutetium PSMA followed by the standard of care. So we're really interested in using lutetium PSMA earlier and also in combination with other drugs to see if we can improve outcomes even further. So we have a trial also combining lutetium PSMA with immunotherapy called the PRINCE trial, and another trial combining it with a PARP inhibitor called the LuPARP trial. And we think we're going to see more and more trials being run around the world. But first, we really wait for this drug to be FDA approved and registered so that it can be widely used and adopted by oncologists and radiation oncologists in the nuclear medicine community.